This is the anatomy of the femoral artery in the vein in the thigh. Abdominal aorta here, iliac artery, and then that divides. And when it comes up here in the external iliac, somewhere here, now it comes down into the femoral, below the groin crease, and it becomes the femoral artery. At the level of the inguinal canal, you have something called the femoral triangle. The femoral artery comes out here, and then it starts coming down, divides into another branch. It continues to call itself the femoral artery, but it divides into a profunda femoris, or a deep femoral artery, and that keeps going down. That supplies this, and this keeps going down all the way, and then somewhere below in the popliteal fossa, it divides into the tibial and the peroneal arteries. The vein is very similar. So it's on the right side of the abdominal aorta, so the IVC, and again it divides, and by the time it comes, the internal iliac vein comes, the external iliac vein comes. Here, the vein is at the level of the inguinal canal. The vein is medial to the femoral artery. So you have the femoral vein here. Okay? Now, the femoral vein is slightly posterior and lateral to the femoral artery. It is joined by the saphenous vein, which runs along the thigh, somewhere here. Now, the vein keeps going down along with the artery, but it changes its course a little bit below. What it does is, rather than be medial to the artery, it goes posterior to it. So right through here, it keeps going down behind the artery, and then somewhere along the lower third, it becomes a little bit posterior and lateral, and that's your relationship. So right through, so around here, it is in a side-by-side relationship with the artery. Okay? So, and side by side, whereas somewhere along the mid-thigh, it becomes posterior to the artery. Now, with ultrasound, what we are trying to do is, we are sending a beam of ultrasound. It goes in and comes out, and what we want, we get a cross section of the image of the structures, of the anatomical structures. Now, we are interested in sampling the vein throughout the course, but we have about 3 or 4 very important levels. So the first is this thing here called the saphenofemoral junction. The saphenous vein and the femoral vein, the junction of these two. Then we get at multiple levels along the thigh, here, 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 and then the popliteal vein. Remember that in the physics tutorial, the ultrasound beam has a very finite thickness, and what you're seeing is only one slice. So Kate, what I want you to do is, I want you to intersect. I want you to keep the probe transversely and give me a transverse section across the saphenofemoral junction. So I've drawn the saphenofemoral junction in that piece of paper. Mm-hmm. Can you do that? Okay, so let's keep here. Okay, let's see where you are.
I think I might be the wrong leg.
So you're here.
Oh.
Okay, now this is the exact thing with ultrasound. Because we can't see the vein, mm-hmm. The first shot, now are you happy that you've got the saphenofemoral junction? So should you be disappointed?
No, because I can readjust. I don't know.
Exactly. That's the point of this whole thing. Okay. Mm-hmm. The first image is always going to be the image that you don't want. Mm-hmm. The first image is, but it's not a wrong image, it's not a bad image, it's a guide. Now, before you keep the ultrasound, this is what you see. You see the skin. Mm-hmm. What you want to see is the internal structure. And short of cutting it open, you're not going to be able to see it. With the first shot of ultrasound, what you're going to do is, you're going to take the skin away and you're actually going to see something. And now you have to make sense of anatomy. So you need to have some knowledge of anatomy. And what you see here is the slice will be going at this particular section. So here, what will you see? You'll find that the artery is superficial, you have the vein, and in an antero-posterior relationship. And you know that the cephalofemoral junction is a place where the relationship is medial and lateral. So, if you know that it's an antero-posterior relationship, what do you have to do? You will now have to slowly slide the probe till you come here. So that's the first important step with probe management, with probe manipulation. Most trainees who are novices do not realize that the single most important thing that they have to do first up is to slide the probe nicely. If you are stuck at this spot, you're never going to be able to get that particular slice. So the best way to do that is choose a transducer that is going to work for that particular study. Have a knowledge of the anatomy, and obviously for the femoral vein, you're not going to go here. You know that the femoral vein is somewhere here. The probe orientation, again, for the first shot, have a reasonable knowledge, and you need to have some way of having a reasonable probe orientation. Here, the probe orientation will be perpendicular, somewhere along the groin. Somewhere along the groin. Okay? Keep it here. If you have, if you're going to get what you want every single time, I'll give you money, buy me a lotto ticket. That's not going to happen. What you do next is recognize what you're seeing. So for that, the first important thing for the first image is you must try to see something that you can recognize. And that particular structure must be good enough to guide your subsequent movement. So if I take an example of the heart, you have to get the heart. You have to be able to see the heart in some way. You might not see the aortic valve, which is what you want to see. You just have to see a moving structure in the thorax. Once you see that, then you know, okay, where exactly am I? And then you start moving the probe towards the structure, depending on the anatomical relationships, towards the structure, using the first image as a guide. For the gallbladder, the big structure here is the liver. Identify the liver first. That's easy. Once you get the liver, search around. And the only way you can search around is move. So for DVT as an example, now you're here, start moving. Okay? And because it's antero-posterior, you know that your structure is going to be superior. That's the next thing. Use anatomical terms such as superior, inferior, medial, lateral. Or you can use cephalad, caudad. I use cephalad, caudad, anterior, posterior, medial, lateral. These are the things that I use. So now start moving the probe cephalad till you reach a level where you have your Mickey Mouse sign in the transverse plane, which is the medial lateral relationship. Then you make fine adjustments. What happens if your patient has a big, say, some ulcer there, and you can't go to the probe, you can't take the probe to that location, or you have a femoral venous catheter, so you have some plastic dressings. If you want a shot of that particular level, but you can't go there, what can you do?
Angle.
Exactly, you angle. You look like that. Ultimately, what you want is for the beam to just go and intersect at that particular location. Okay, so that's the first fundamental thing about probe movements in ultrasound. The first shot is always going to be a wrong slice. The first shot is for a guide. You have to know how to orient the probe and how to keep the probe on the skin as a general guide. And then using the first shot as a guide, you start making appropriate movements. And the movements that I use are deliberate. I call it moving or sliding. I deliberately slide. So the various different motions I use are zigzag, like this, up, down, at the same time going medial to lateral, so like that, up, down, in a particular direction. The other thing I could do is, you could just keep it here and deliberately go in a circular manner. Okay? Essentially, what you do is, as soon as you hit a structure, as soon as you see a structure that you can recognize, you can stop, interrogate it better, see whether that's the ideal thing. Otherwise, you keep going. Okay, right. What do you do next? You identify the saphenofemoral junction. After that, you have to look at it. You have to, once you get the ideal view, you optimize the technical settings. Make sure that the image gain is good, the depth is good, and after that, you interrogate the vein for the presence of DVTs. And we've already seen in the DVT tutorial, you look for echogenic material and you look for compressibility. For compressibility, you go here and press hard against this so that the vein completely collapses. If the vein has a clot, it will not completely collapse and you might see a small gap. Anyway, you can watch that on the DVT talk. But now, once you've got your shot, you apply compression. You do other maneuvers such as pulse wave Doppler, you do the color Doppler and so on. And then you now start moving down. When you start moving down, how are you going to, once again, you have skin. So in what direction are you going to move down? So you can see this, but you have skin. How do you know which direction to move? Because you already have the vein inside, follow the vein. Just make sure the vein never goes out of the screen. So the simplest thing is the structure of interest must always be in the middle of the screen. So if the structure of interest is in the middle of the screen, it means it's in the middle of your probe. Okay? As you're going down, so that's the vein there. Okay? If I go vertically like this, what's going to happen? So here, the vein is in the middle of my screen. As I keep going down, what's going to happen? It's going to go off to one edge. If it goes off to one edge, all you have to do is redirect, go back. Bring it back to the middle, go back. As long as you have the vein always in the middle of the screen, it means it's in the middle of your probe. And that adjustment has to just be made. Just follow the vein, and at each level, go and press hard, make sure it compresses, and keep going down all the way. Around here, the femoral bone, the femur will come, and the vein dips behind the femur and goes into the popliteal fossa. So somewhere here, you lose the vein in the artery, in which case now you bend the knee, you go from the posterior. Okay? And same thing in the posterior, you actually have much less of a space to play with. And same thing, you go there, you might be able to slide the probe up and down a little bit, but mainly you stay at one place and you tilt up, tilt down, and you search for the big fat popliteal vein, and then you press. So that's the simple thing. Happy to go for the hands-on at the bedside?